Hi, I'm Dr. Gamaliel and I apologize I can't be with you in person today at the lecture. I'm an orthopedic surgeon by training with a subspecialty focus in spine surgery. And today I'll be talking to you about falls in older adults, causes, consequences, and prevention. Later on also in the later half of the talk, I'll be talking to you about osteoporosis, which is having fragile bones and how that can impact fragility fractures should they have a fall. Disclaimer before the talk. Falls are a significant cause of morbidity and mortality in those aged 65 and above. In a Duke series, brief research series in 2018, they found that about 13.4% of Singaporeans aged 65 and above experience a fall, and that rate increases to 17.7% for those aged 85 and above. All these falls account for about 85% of trauma cases in the elderly population when they present to emergency department, and that's a huge load on the medical system. The prevalence of falls in other countries, Singapore is about 13.7, China 18.7, Hong Kong 19.3, Japan 23, Malaysia 27.3. So that rate of falls can actually increase in other countries. The risk factors for having a fall can be divided into intrinsic and extrinsic. Intrinsic is something that is within the patient, things like their strength and their balance, which then reflects their frailty, whether they have medical comorbidities, including mental and social issues. Extrinsic refers to things in the environment. Any trip hazards, how about the floor? Is it wet? Is there a gradient? What kind of footwear are they using? Are they on medication that can cause them to be drowsy or to have a fainting spell? This is a study, the phase study in 2011 on 5,000 respondents in Singapore, and it divided the population by age, by gender, by ethnicity, and their marital status. So patients aged older, 85 versus 65, of course, you can see that the fall risk increases from 13 to 17%. Between male and female of the same age, females have a 15.5% risk of falling versus males 10.9%. So females more than males. By ethnicity, Indians 20%, Malays 15%, Chinese 12%. So within ethnic groups, you can also see a difference. Between married and not married have a slightly higher risk of falling, 16 versus 11%. Risk factors for falls are correlated with frailty. So if patients are frail, then higher risk of falling. If they have more than one mobility difficulty, they're using a walking stick, walking frame, higher risk of falling, 20.2% versus 8.9%. If they have difficulties with activities of daily living like dressing, taking a shower, higher risk of falling, 23 versus 12%. If they have difficulties with independent activities of daily living like cooking and shopping, higher risk of falling, 23% versus 11%. Frailty scales, this one is just an example taken from Dalhousie University, can vary, right? The one here shown has 9 grades from 1 to 9, very fit to terminally ill, and in between varying grades of frailty. So if they get to level 4, grade 4, they're vulnerable, they're using a walking aid. Mildly frail, walking frame. Moderately frail, they'll need help with activities of daily living. Severely frail, they'll be in a wheelchair. Very severely frail is usually bedbound. Other risk factors, intrinsic risk factors for falls are comorbidities. So if the patient has one or more comorbidities, higher risk of falls. Comorbidities include things like heart disease, hypertension, stroke, cancer, diabetes, arthritis, mobility issues like Parkinson's. So if they have no conditions, 10%. If they have one condition, it jumps up to 13.6%, 2 or more, 15%. If they have sensory impairments, they are also at risk of falling. Poor vision, 27.9%. Poor hearing, 26%. They are in pain due to arthritis or neuropathies, 17%. So all this in sensory impairment increases their risk of falling. Mental health, they're depressed, they're feeling lonely, again their risk of falling goes up. After the fall, there are side effects, right? Consequences. So they can get physical trauma. They can get a bruise, a contusion, abrasion, which is painful. Worse still, they can get a fracture. In orthopedics, the ones that we see are wrist fractures, spine fractures, hip fractures. After the fall, there's also the psychological fear of movement leading to deconditioning and a vicious cycle of increasing falls. So in the Singapore Medical Journal 2020, they published a little diagram that shows after the fall, patient has a fear of falling, decreased activity, reduced muscle strength and balance, decreased function, leading to increased risk of fall, which is a vicious cycle. There's also the burden and cost to the family, because now the family has to seek treatment for the injured person. They have to pay for that. Later on, I'll show you the cost of treating hip fracture in Tan Tock Seng 10 years ago. And then also the burden. Somebody has to take time off from work or time away to look after the person who has fallen, and they may need care for activities of daily living. In the US, it costs about 23 billion per year, UK 1.6 billion a year. In Singapore, the numbers have not been studied, but I'm sure it's not a small amount. This is a picture of a hip fracture. I'm going to the first of 3 fractures that we see in the typical orthopedic practice for fragility fractures. Hip fractures is one of them. 2 types of hip fractures, neck of femur fracture and the intertrochanteric fracture. So in the top row, on the first left two, you see neck fractures. And then the top right is the intertrochanteric fracture. So depending on the fracture that they suffer, we have to use different ways of securing or fixing or replacing the injured joint. In this X-ray, you see someone who has suffered a neck of femur fracture it was lucky that it wasn't too severely displaced. It's an 84-year-old Italian guy who sat down too hard in the toilet, and then he suffered a hip fracture. And he was frail because he was very thin. He was a cancer survivor. He wasn't moving around much anyway. So he had very poor muscle mass. And after the fracture, he couldn't move. So after we put in the femoral neck system, his pain was a lot better, and he was able to be cared for, at least in a wheelchair, rather than be bedbound. And he was able to ambulate with a walking frame, short distances, but wheelchair when going out for longer distances. But it takes about 3 months to heal. So that's a bit of a downtime for a patient who is old. This patient had a more severely displaced neck of femur fracture, and we had to replace it with a total hip. In other cases, a hemiarthroplasty. The cost of fixing a hip fracture can be high. In this SMJ paper in 2017, the doctors actually studied patients who were admitted to Tan Tock Seng in 2011. 2/3 of patients had surgery, 1/3 of patients were not fit for surgery due to comorbidities and had to undergo conservative management. Average length of stay was 2 weeks, not a small amount, and 2/3 of them were discharged to a step-down care like a community hospital. In Tan Tock Seng is Ren Si Community Hospital, Ng Teng Fong is Jurong Community Hospital, NUH is St. Luke's, but you can see that most of them were not able to go home. 6.5% complication rate, the most common being pneumonia and urinary tract infection, UTI. Others are stroke, heart attack, deep vein thrombosis, wound infections, sacral sores. Mean cost for patients undergoing surgery was 14,000 after subsidies, 9,000 if they are non-surgical. So this is a government hospital 13 years ago. I'm sure the cost will be higher now. And if this was done in a private hospital without any subsidies at all, the cost much higher. Hip fractures mortality rate. So this paper 2016 by Dr. Eileen Tay looked at 340 patients who had a hip fracture and divided them into surgical and non-surgical treatment. And then she looked at the mortality, how many of them died at 1 year and 2 years. So the surgery went well. They didn't die from the surgery. But at 1 year, 4.4% of those who had surgery for the hip fracture, successful hip fracture surgery, died. At 2 years, 9.1%. For those who had non-surgical management because they were too ill in the first place to undergo surgery, 10% died in the first year, 15% died in the second year. So hip fractures, amongst the orthopedics community, we have a saying, we come out through the pelvis, through a normal delivery, but we go out through the hip fracture. Wrist fractures, the other common fractures that we see, because on the fall of an outstretched hand. So if they have a fall due to frailty, lack of balance, and then they try to break the fall by stretching out their hands, they break their wrist instead. And if it's a minimally displaced wrist fracture, we can try to pull it, manipulate it in the emergency department under a Bayer's block or a hematoma block, and then we cast it If it's too severely displaced, then we have to do open reduction and internal fixation. Basically, it means they have to be admitted, get them into OT and fix it, and then they have to go for rehab for both of these cases, because the fractures take about 3 months to heal. Right? So after the cast is removed, or even after surgery, they need to be referred to the hand therapist to increase their mobility and strength. Spine fractures also very common. The 3 fractures: hip, wrist, spine. So for spine fractures, if it's not severely compressed or not severely deformed, we can do a trial of bracing. So in this, again, an 80-over-year patient, toilet, 2 helpers, sat down too hard, broke the spine. So you can see the L2 fracture on the x-rays, where the arrow is pointing. And then a sequential x-ray done 1 week later shows further compression. But this patient was amenable to bracing, so she had a lumbar corset. But technically they need a thoracolumbar corset, which is a much bigger one, very warm, and not easy to put on. So, and not cheap either. Depending on the vendor, it can range from 1,000 to 2,000 plus for TLSO. If the fracture is worse and the patient is really in pain, can't get out of bed, can't sit out of the chair, then we advise them to do a cementing called kyphoplasty or vertebroplasty. This procedure, we actually do it in the operating theatre under X-ray guidance, or in the CT scan room under CT guidance. Put in a balloon, inflate the balloon with saline, create a void, withdraw the balloon, inject cement, stabilize the fracture straight away. Pain goes down significantly. Still a minor surgical procedure, so the risk of this procedure is cement extravasation. Meaning if the cement went posteriorly into the spinal canal, it would impact on the dura and the spinal nerve roots. And in these cases, if there is neurological deficit, we have to go in and surgically remove the cement. Thankfully, it's a very, very rare occurrence, but you have to be careful about this kind of things. And the last one is surgical instrumentation. So if the deformity is very bad, no choice, we may have to put in titanium screws and rods. In osteoporotic patients, we have to augment the screws and rods with cemented screws, fenestrated screws. So we inject cement into hollow screws, then the cement interdigitates with the bone and prevents the screw back out. Moving on to osteoporosis. Osteoporosis of fragile bones can predispose one to having a fracture after a fall. And the risk factors for osteoporosis are age, right? So the older you are, higher risk of osteoporosis. Low body weight. If you're underweight, also higher risk of osteoporosis. Early menopause. Certain medications like steroids. Low calcium intake of less than 500 milligrams a day. Excessive alcohol, more than 2 to 3 units of alcohol a day. Smoking, prolonged immobility. All these are risk factors for osteoporosis, and they should be screened. So as a pharmacist, if you look at this osteoporosis self-assessment tool for Asians, it's a very quick and easy way to screen your patients for osteoporosis. So on one column, look at the age. So let's say you are 70 years old, or the patient is 70 years old, and then you look at the weight. If the patient is 49 and 74 years old, 49 kilos, they are at high risk of osteoporosis, and they should be screened with a bone density scan. If they are 85 and they are weighing 60 to 64 kilos, again, high risk osteoporosis, recommend bone density scan. Another tool, a little bit harder to use because it's online, is the FRAX score. And this one can be customized for continent, country, ethnicity, but you do need a femoral neck BMD, question number 12. So before they can do a FRAX, you need a BMD. But once you have the BMD, you can plug in your age, sex, weight, height, and any risk factors for osteoporosis, and then it spits out a 10-year probability of fracture, major osteoporotic fracture, and hip fractures. Now this is a BMD report, right? You can see on the left-hand side is the hip BMD, right-hand side is the spine BMD. And if you look at the color chart here, the arrow or the crosshair shows where the patient's BMD is. In this case, the hip BMD is in the red zone, means she's osteoporotic, more than -2.5 key on the T-score. And more than -2.5 is osteoporotic by WHO standard. So you can see here, her total average score is -3.1, and the WHO classification is osteoporosis, fracture risk is high. Her corresponding spine BMD is osteopenia, yellow zone, between -1 to -2.5. So we normally just take the worst score. And usually the one that's reflective is the hip score. Now, so if you detected or you screen and you detected the patient is osteoporotic through an All-Star screen or BMD scan, also do a vitamin D level check, serum vitamin D level check. Many Singaporeans are indoor, their vitamin D levels will be usually deficient, and vitamin D is needed for gut absorption of calcium and for bone health. So if the vitamin D levels are low, we may need to top it up. But once they reach optimal levels, we can maintain it. So in terms of supplementation, about 600 milligrams per day, 500 IU of vitamin D is sufficient if they are normal. But if the vitamin D levels are low, they'll be replaced before we can go into maintenance. This one is a guide to osteoporosis treatment downloaded from the Ministry of Health Agency for Care Effectiveness, and they've done a very nice summary of the different medications that doctors can use to medically treat osteoporosis. On the top row is the bisphosphonates. They are things like alendronate, risodronate, ibadronate. They can be taken for vertebral fractures, non-vertebral fractures, hip fractures, provided they have good renal function and no history of gastroesophageal reflux. So it's taken once a week, and empty stomach, 1 glass of water, sit upright 30 minutes before moving on to breakfast or other medications. Alright, so how the bisphosphonates work is by inhibiting osteoclasts. Osteoclasts are cells that remove calcium from the bone, or they remove unhealthy bone. So they help in the remodeling of bone, because osteoblasts lay down the cell, the good bone. Osteoclasts remove the old and unhealthy bone. Denosumab is also injectable. They also work by inhibiting osteoclasts, right? And it's given injection every 6 months. So for patients who have compliance problem, they're forgetful, they can't do their weekly oral meds, then suggest denosumab Prolia injections, 6 monthly, no compliance issue, as long as they come every 6 months for the injection. Now, to note is that bisphosphonates, usually before we start them, we make sure so they go for dental clearance because of the risk of osteonecrosis of the jaw, and we usually take a drug holiday every 3 years because of the risk of atypical femur fractures if they are longer on bisphosphonates longer than 3 years. Then the next one is the anabolic bone building medications like teriparatide and Evenity, romosozumab. Evenity is spelled with E, E-V-E-N-I-T-Y. And these actually stimulate osteoblasts to lay down new bone. Right? So the first two, bisphosphonates and denosumab, they inhibit osteoclasts. Teriparatide and Evenity stimulate osteoblasts to lay down new bone, so they actually build up the bone density quite nicely. They're indicated for vertebral fractures and non-vertebral fractures, but not for hip fractures. So in summary, we have to recognize and intervene early. If they are frail, consider referring them to the physiotherapist or to a trainer to help them get back their strength, right? So they are at less risk of falling. If they have comorbidities that can predispose them to falling, make sure that the family physician or their doctor is on top of things. As a pharmacist, you can help them do med recon, because a lot of the elderly on multiple medications, polypharmacy. So try to see whether it's necessary to take so many medications. If they are isolated, poor social support, consider referring them to an active aging or community worker. If they are already diagnosed with osteoporosis through a BMD scan, Then, of course, you can refer them to orthopedic surgeon or endocrinologist to manage the osteoporosis. So falls are a serious event. No, they are not without problems. They do carry significant morbidity and even mortality for patients that I've shown you before, right? 5 to 10% at 1 and 2 years. So, and the prevalence of this is increasing because of our aging population. So we have to screen for them and intervene early, because the risk of fractures is increased if you are osteoporotic. So prevention starts early. Peak bone mass at 40. So exercise, weight bearing, sunlight, supplementation if needed before 40, and then after 40 it tends to goes down, but doesn't mean that we can still give supplements to keep the curves high. So early screening with the OSTA, with a BMD is needed, and then if they have osteoporosis or if they are at risk of falling, intervention is critical. Thank you so much for your attention. I hope the lecture was useful for you and you got some education out of that. If you do have any questions, please leave them with the organizers and I will get back to you on them. Thank you so much.